This is Stanford Engineering's The Future of Everything podcast, and I'm your host, Russ Altman. If you enjoy The Future of Everything, please follow or subscribe wherever you listen to your podcasts. That will guarantee that you never miss an episode, and it will help our listenership grow. Today, Alyce Adams will tell us why people with chronic diseases can have vastly different health outcomes. Just because you have access to healthcare doesn't mean that it serves you well. You still need to get to your appointment, communicate effectively with your provider, get your medications. None of this is a given, and we need to work to ensure that folks turn access into good health. It's the future of health outcomes. Before we jump into this episode, a reminder that if you enjoy the podcast, please take a moment to rate and review it. It will help fellow listeners discover and understand what this show and the future of everything is all about. You know, chronic diseases like diabetes and cancer require long-term medical care. But if you are poor or live in a rural environment, access to medical care can be a real challenge. Even if you have access, you need to be able to use that access, and there are many ways the system can fail you. And if you don't get the care you need, then you, your family, friends, and society will suffer. How can we create policies and interventions to make sure that the dollars we spend on healthcare are effectively used to help patients? Well, first we need to understand where are the bottlenecks in the delivery of care, and then we need to remove them. Alyce Adams is a professor of epidemiology and population health, health policy, and pediatrics at Stanford University. She studies the racial and socioeconomic disparities in chronic disease outcomes. She will tell us that although funding is of course important, we must also listen to the patients about what is important for them and their health, and where the barriers are for them to getting the best health. This will help us understand how we can best intervene to make sure that they get good care. Alyce, you study differences in outcomes for people with chronic diseases. Can you just start out telling us what are the key drivers for these differences, and then we can get into how we should study them?
Absolutely. So first of all, I would say that the most common chronic disease is multiple chronic conditions, right? So most people don't just have diabetes or just have cancer. They have multiple chronic conditions that affect their lives. And so what we see is that for certain communities, particularly communities of color, lower income communities, communities with lower educational attainment, they tend to get these conditions earlier in the life course, and they get more of them earlier on. So that's the piling on, if you will, of chronic conditions happens fairly early in some of our populations. And the drivers of those, really the social determinants of health, all of the factors that we see, certainly with COVID, we saw this, right? Where people, if you live in certain neighborhoods, you have less access to certain things, and that sort of compounded the issues related to COVID. In similar ways, those mechanisms have been going on in our society for a long time, and they perpetuate this higher rate of chronic conditions in some of these populations. And so what we try to do is better understand what these drivers, try to identify those that are actually modifiable through health system and policy interventions, and then work collectively with communities and health systems and others to see if we can design better interventions that have the potential to address and really alleviate this burden for many of our patients in our populations.
Great. Thank you. And I have looked at a lot of the papers you've written over the last few years. And of course, I think many people understand, even intuitively, that if you're poor and if life has been challenging, your health might not be as good. But I know it's much more complicated than that. And it's not a question. So, you might say, okay, they don't have enough resources. Let's throw some money at the problem. And of course, people always like throwing money. But I notice in your work that you've looked at this and there can be mixed results. So tell me about the complexities of these issues and why it's not just poor people have bad health.
That's a really great question. And so I would start with some of our work that we've done around improving access to healthcare, to high quality healthcare, right? So often what we talk about is one of the core drivers of the disparities is differences in access to high quality care. So what we've tried to do is to understand, well, when the government or even health systems make healthcare more affordable for people, what does that do to these disparities? And what we see is, one, is this a good thing? Yes. Overall, when you improve access to high quality care, what you see is an increase in the utilization of clinically essential medications for treatment of chronic conditions like hypertension, cancer, diabetes. People are actually using this sort of resource, this benefit in a way that helps them out. The challenge here healthcare is that those types of initiatives have only had a modest effect on the overall disparities that we see in terms of clinical healthcare outcomes. So you kind of scratch your head and say, well, why is it? We thought if we turned on this spigot, then all of a sudden all of these people would get access to this valuable resource. Well, the challenge is that if you think of it as a spigot and a hose, where we're trying to sort of address this particular need, what happens is there are a number of other factors that cause kinks in that hose. So, for example, a kink in the hose might be that while you have access to healthcare in terms of having health insurance, you may not be able to get there very easily, either because you don't have great public transportation where you are, or because you just don't feel comfortable within the healthcare setting where you're at, because you don't feel like people are treating you with respect and kindness.
Right.
Another type of kink in the hose is that when you get into the healthcare system, no one speaks the language that you do. And so it makes it very difficult for you to be able to communicate your needs. And they go on and on and on. And so if you imagine that hose again and all those different kinks, it's easy to see how very easily, even if you turn on that water, you're only seeing a sort of a trickle by the time you get to the end. And so our job as scientists is really to understand those kinks and how do we undo them systematically, and sort of figure out how do we keep that water flowing.
So how does this research happen? This is great. You've given us a great setup, and I can see the problems. And I love the garden hose and the kink analogy, because it's just anybody who has dealt with that knows that this is an issue. And it's also, I've learned in the last 30 seconds that access doesn't mean full access. It doesn't mean that you're showing up and you're communicating effectively with your provider. Access has kind of a technical meaning of you're allowed to come to the clinic, but it doesn't really mean that you have come and the clinic is set up to accept you, welcome you, and engage with you. Okay, so that's very important. How do we study this? Is the data good? Do electronic medical records help? Is it way more than that?
Yeah, so yes to all of the above. I think why I get excited about this work, in particular in the area of prescription medication access, is that we monitor prescription medications on a routine basis. We know when you get a prescription, we know if you've picked it up, we know if you come back to get it. These are all transactions, right? And we can follow transactions using electronic health record data as well as claims data, sometimes linking those two things together, as well as linking them to other types of data like what's going on in your neighborhood. Do you even have a pharmacy close to your house? How far is your house to the medical center, right? All of those things we can pull together in sort of these big data sort of ways and really look observationally over time at the same people and their experience over time with different types of medications to really start to, again, sort of unravel that hose. So one of the areas that we look at in terms of policy are federal and state policies that impact large swaths of the population. As scientists, we talk about experiments a lot, but the reality is policies are also experiments. They're natural experiments, right? We don't necessarily control everything that happens, but the reality is there are these huge things that happen to large numbers of people, and often we never even ask what happened and whether they were positive or negative on the other end. And so what's great about those natural experiments is we can identify the populations affected and then really study over time what happens, which is what we've done with Medicare Part D, for example. We've also done this with Medicaid state policies in order to really evaluate, did that policy have the effect that we intended it to have? Often what you find is policies, even when well-intended to increase access to a given service, what ends up happening is when the policy gets implemented, all of those factors that influence implementation, whether it's adopted, whether people even understand it, all of those things actually may have a different effect and take the policy in a different direction in terms of its effect on different populations. So one clear example is prior authorization. So that's where state Medicaid programs, for example, will say, for certain drugs, because they are more expensive and there are alternatives available, we are going to require the physician to ask somebody for permission before prescribing. And what we've shown in the past is that depending on how these things are implemented, while good intent there, right? We want to save money. We don't want people wasting money. At the same time, sometimes what ends up happening is if the policies are too complex, when these policies go into effect, a clinician may not understand that certain groups are exempt from the policy, nor do they necessarily have time to look up which groups are exempt from the policy. So what they end up doing is sort of avoiding the hassle. So if the prior authorization creates hassle, it's also an administrative burden on the health system. They might just avoid it altogether. And so you can actually dramatically overnight shift people away from specific classes of medication, regardless of whether or not they could benefit from those medications, simply because we've put up a barrier that clinicians can't navigate very well.
The prior authorization, in my previous life as a practicing physician, though I looked at those with dread.
Yes.
because either I was in a clinic where I was the one who had to fill it out, or I was in a posh clinic where there was administrative assistance, and just as you described, it totally determined how quickly and how well the form was filled out. If there was an administrator who knew how to do this and who I could say, could you please fill out this form for Mrs. Jones, and this is the reason why we need the drug, versus, oh my God, I'm 12 minutes behind, I'm 20 minutes behind, and now I have to fill out this form. And so it totally makes sense. And I'm guessing that it's funny because as you describe these access problems, it sounds to me like there's at least many groups, but you talked about, the poor and the poor in cities who might not have transportation and access. And I'm also thinking that this must be a very similar set of issues for rural folks who are far away, who have to tend to whatever they do for a living. Do we see big differences in those two populations, or do they wind up looking very similar?
Oh, we do see big differences, particularly in rural communities. When you add on the fact they often don't have public health infrastructures, and we know that there are these deserts out there in terms of healthcare access, right? So in some places, there are fewer pharmacies available. There may be fewer clinics where people can actually get treatment for sorry, I'm blanking out right now on the sort of specific treatment I was going to say, but really sort of there are specific types of specialty care, I should say, that are harder to get in rural areas. Right. And so when that happens, it compounds already existing inequalities in terms of income, in terms of education, in terms of language, in terms of access. I'll give you an example right here in Northern California. While I sit here in Silicon Valley, and so people have an image of what Silicon Valley is, the reality is the county in which we sit actually has some of the greatest divisions between the rich and the poor in the entire world. And that's because if I drive down to Monterey Bay, when I get just an hour or so outside of Palo Alto, I see people out there working in the fields, exposed to all kinds of pesticides, exposed to the sun, dealing with poor water quality control, all sorts of things on top of what we're already dealing with in inner cities. Yes. Right. So that particular population is underrepresented, right? They don't necessarily have a collective voice often. They're often forgotten. They may be undocumented. So you have additional legal concerns for their behalf in terms of seeking out care. So absolutely, it can be much worse in those areas. And we really have to think globally when we think about inequality, and not just in terms of a specific place or a specific subgroup, but really what is inequality doing for all of us, or doing to all of us, and how do we work together to address it?
Yeah, that really, really, really good and really clear set of challenges. So you've written a bunch of stuff, period. But with some of the things that really caught my interest is you wrote about disparities in kind of patient knowledge and understanding of their disease. And I think at least the paper that I saw was about tobacco use, but I imagine it applies to many other areas. How do we study that? And what are that's a hard one, right? Because if you're not even signed up for the whole mission of health because of your life experience, you can imagine how frustrating and difficult it would be for providers who want to help to get you on board with the plan. So where are we with that, and what are the options there?
That's a great question. And it's actually that kind of question that has really been driving our more recent efforts to integrate patient, caregiver, and other voices into the research we do as research partners, not just research subjects, from the very beginning. And sort of learned this early on, even working with policymakers, is that I can come up with a gazillion questions as a researcher. I'm naturally curious, right? So I love asking questions and I love questioning things. So it's no problem for me to come up with a question, whether I'm asking the right questions or the questions that really address the priorities of those most affected is a different issue, right? Yeah. The only way I can get that is by talking to those people. So early on in my career, I started to talk with policymakers, whether it was tribal leaders, if I was working on Native American health issues, or members of Congress or state legislators. And now a lot of my work involves patients from the very beginning. What that does is it reorients our thinking. Instead of me thinking about maybe clinical outcomes that NIH, National Institutes of Health, cares about necessarily, they've got me thinking about about, well, what about my functional health, right? You're talking about my A1C. I want to be able to mow my lawn, or I want to be able to take care of my grandkids. Their orientation and their priorities are different. So they've really shaped how we think about the questions that we ask, the outcomes that we're interested in, and then how we pursue them. And it's only by doing that, I believe, that we can fully understand how to integrate sort of what patients are thinking about and what communities are thinking about into the work that we do. And so a lot of what we do ends up being mixed methods. So while I may be a big data person, that's sort of how I was raised. For me, in terms of my background, but I think for me, what's been really enlightening and wonderful to learn about is qualitative methods and how we can integrate those more seamlessly into the work that we do so that we can actually understand the data that we see. Numbers are just numbers. To understand people, you have to talk to people.
So that sounds great. And the idea of involving the patients and their providers really is very compelling. However, you and I know very well that there are populations that don't feel well served by medical research. So I'm guessing it is not a walk in the park to say, hey, we're going to do this great research with you. Come join us. Because some people might say, well, wait a minute. I've heard a lot of stories that are true about my group, my cohort not being treated well by the medical research establishment in the past. Does that come up in these kinds of projects?
All the time. And I think, part of it is, as researchers, we first have to walk in with a great deal of humility. I may know my field of research really well, right? I may understand how to run natural experiments incredibly well. However, I don't know what it's like to live in some of these communities, multiple chronic conditions, sort of having the weight of historic oppression on top of it. I don't have that experience, right? I come from a different place. And so having the humility to understand that I don't know everything before I walk in the room is incredibly important. So I think researchers first have to do their own homework to understand what's the history there. The second thing we have to do is acknowledge it. We can't pretend like I sit in an ivory tower. I'm here at Stanford, right? I can't pretend that Stanford has not had a very negative impact on the communities that live here. So for me to sort of pretend that doesn't exist doesn't help anybody. So
you have to get it out on the table.
We have to get it out on the table. The third thing we have to do is listen, and truly listen in order to understand. So rather than sort of go in to say, I need a clinical trial run, how do I get there? How do I get people signed on to my study? You have to go with a completely different mindset, which is, how can I be a good partner to these communities? And that's what we're trying to build here at Stanford. We have an Office of Cancer Health Equity, where we're really working directly with communities. We have a wonderful community advisory board. We were out in East Bay just about a week and a half ago with the whole sort of cancer service line team, right? We all went out to the East Bay, and it was remarkable to be out there to talk with people about their experiences. Many of them had never seen Stanford in the community before. So that was humbling for us. But it was also incredibly important for us to hear that, to hear what they think about Stanford in order to have that conversation, and Stanford research in particular. So I think that engagement and showing up consistently and maintaining that humility. And the last thing that I've learned this one of my community partners, Ms. Libby Hoy, who has her own patient group that she PFA Network and PFCC Partners, which is a group of patients and caregivers and others really focused on integrating. How do we sort of systematically integrate patients and caregivers into health systems and into research? And she always tells me it's about the infrastructure. You have to set up an infrastructure, create a charter which delineates what the goals are and what we're going to do. You have to have a North Star, right? Something that we're all working towards together. You have to agree ahead of time. What does engagement mean? What does it look like? And you have to constantly evaluate the process. How are we doing? Is it working for all the partners? And those kinds of things. It's only through that iterative process. It doesn't mean you're not going to make mistakes, but the chances of you being able to come back from those mistakes is much higher if you show that consistency and that willingness to work in sort of bipartisan relationships with community partners.
This is The Future of Everything with Russ Altman. More with Alyce Adams next. Welcome back to The Future of Everything. I'm Russ Altman. I'm speaking with Professor Alyce Adams from Stanford University. In the last segment, Alyce told us about the challenges of ensuring that people with chronic disease from poorly served communities get the health care they need. She told us that policies with good intentions can sometimes lead to not improved outcomes. In this segment, she will tell us how research is becoming broader and how engaging patients and their providers is giving us information that's critical for removing the barriers to care. She will also tell us that policymakers are listening and they are opening to using data to make new policies and interventions that maximize the chance that people with chronic disease will get good care. And Alyce, I wanted to ask you, I think this falls generally under the field of health services research, health policy. How is that field doing, and what does the future hold? We hear about AI. Is AI making an impact in this field? Where are we going?
Absolutely. So health services research has been around for quite some time, even though most people probably don't know what that is. And I think the reason is that it's inherently multidisciplinary. We sort of bring together sort of the strengths of fields like economics, statistics, political science, a lot of different types of fields, and try to use that information or try to use those theories to fundamentally understand how individuals utilize healthcare services, and what are the influences of various factors that influence their access to those healthcare services, and what can be done to really drive us towards greater efficiencies, sort of lower costs, but sort of higher bang for the buck in terms of what we get out of it, but also really trying to understand inequities in the system and how those can be adjusted, right? So if you think about healthcare as sort of a public good, if you will, something that we all strive for and that we think everyone has the right to, the question then becomes, well, we know historically some groups have underutilized, we've all underutilized things that we know are beneficial to us, and we know that that's complicated. That's not just about individual human behavior. Right. That really also sort of encapsulates the interactions between people and their providers, the context in which care is delivered in terms of the healthcare system. What kind of health system is it? Who owns it? How is it run? How is it organized? Who's on board to actually provide care in those systems, and how are they paid? How do we evaluate the quality of care, all the way through to policymakers who decide how they get paid, how much, what's appropriate sort of nursing ratios. There's like so many different financial and organizational aspects to that. And really AI is helping us to think about this in a number of different ways. So one of the things is that we know that health is complicated. Even any given disease is very complicated. There are a lot of different variables that go into understanding sort of whether someone's at risk for a particular disease and what their prognosis will be and what their trajectories will be. It's nearly impossible for a given individual to hold all of those different factors in their heads as they're making a decision, is what we ask of clinicians. So a lot of the work that we do in AI, particularly in the healthcare context, is to build algorithms to augment decision-making by providing additional information and or really trying to understand and bring together diverse sets of information for the provider in a cogent way, such that when they're sitting there with the patient, or when they're thinking about an overall patient panel, or the health system's thinking about implementing some sort of intervention, we can use AI to help inform that practice. So, for example, we developed an algorithm at Kaiser Permanente Northern California when we had been talking with patients about diabetic neuropathy, which is nerve damage that's caused by diabetes. It's a leading cause of risk for lower extremity amputation in the world. So we noticed that a lot of patients were talking about neuropathy, but really did not necessarily have the conversation with their physicians about that condition. So we said, well, there's something going on here. We worked with them very closely to better understand what was happening. And one of the things we realized was, for a clinician, they could not tell for the patient in front of them what the likelihood was that that patient in particular was at particularly high risk for a bad outcome versus another patient. And when you have so many, up to 50% of diabetes patients who are adults who've had diabetes for 10 years or more, who have neuropathy, that's problematic. So we've developed...
And one of the things you said is that this is not just about the diabetes disease. There's a zillion other things that physician might not know about, and this could be helpful in that way.
Absolutely. So taking all of the different, so these large electronic health records, taking all of this diverse information and pulling it using machine learning to pull all that information together to provide a simple risk score, if you will, for a given patient that enables the physician or the clinician who was ever working with the risk score to sort of make different decisions about a particular patient's risk. And so we look to see like adverse events over the near term. And so you see, algorithms are often used in that way in healthcare settings, is really to help us assess risk, either for individuals or for groups of patients, in ways that help doctors make better decisions.
Great. So I'm glad you gave that example, because it is so rich, and I'm exploding now with questions because there are many perspectives. As you said, this is a multidisciplinary field. There's many players that have different or only slightly aligned interests. You mentioned payers who have a certain perspective, and then clinicians, patients. Then when you implement these algorithms, how do you think about the perspective, like whose priorities should be encoded in these algorithms? And then how do you make sure that those priorities are actually being encoded and not some priorities of somebody who's saying, my only goal is to spend the least amount of money, in which case there's going to be a certain number of decisions that are going to be obvious, like no, no, no. So tell me about that.
Oh, it's incredibly rich and exciting to be working in this area. I would say one of the things we thought about from the very beginning was who's going to have access to this information and how will they use it, right? Because that's going to dictate how comfortable physicians feel about it, how comfortable patients feel about it. So one of the first things we decided is this will not be something that sits in the hands of the health plan. So someone who's deciding who gets covered or not. Right, it can't sit there. It has to sit with the clinician who is the trusted provider of the patient. Right. We also talked about sort of which clinician, right? Who actually is going to use this? Is it the primary care physician? Is it a nurse practitioner, or is it someone else? And that really depends on the healthcare system in which you're working. So at Kaiser Permanente, which is a physician-run organization for the most part, we definitely have a lot of nurses and others. Often it's a physician making a decision. So we worked with physicians to then design the algorithm, essentially, not the algorithm itself, but how the algorithm might be used. But here's the rub. The challenge here is it's almost impossible to anticipate all of the different ways in which these algorithms could be used or misused, right? We also have to think about subgroups who are inherently harmed by these algorithms because of biases in the data itself that then get perpetuated. We also have to think about, again, how others might interpret the results of the algorithm and how those results might be interpreted differently depending on who's sitting in front of them. Right. So none of those things go away. So more and more we're pulling from the bioethical literature and from our bioethics experts to help us sort of delineate what are some of these pitfalls. So what are the benefits and what are the pitfalls? And then how do we think about those things from the very beginning when we're initially designing the algorithm? So we're really taking more of a systems level approach. I think when we started in healthcare, it really was, we want a tool and we want to employ that tool to address a problem. Now we're realizing it's not enough to just focus on the tool. You really have to think about the whole system in which the tool is being implemented, because that's really what's going to dictate whether this algorithm on the whole is going to be helpful or harmful to individual patients or to individual communities.
That's great. And that leads me in the last couple of minutes, I wanted to ask you about policies. So you said at the very beginning of our conversation that policies, we can think of them as little experiments where we make a perturbation and then we are hoping that the world is a better place because of the policy. And then you said part of your goal is to actually do the follow-up so we understand the implications. So what is the future of these policies? Like, where are we starting to see that because of the work that you and your colleagues do, that the policies are now coming in with a little bit more information, or is that a Pollyanna-ish thing to say, and we're going to continue to have kind of random policies that we then always study in arrears but not prospectively?
Gosh, I wish I could tell you yes. I really wish I could. I think some of the challenges are that even when policies are well-meaning, by well-meaning, I think they're being written by thoughtful people who are trying to make things better for everyone as opposed to making things worse for a specific group, right? So even in the best circumstances, when policy is done that way, often it's driven by budgets, not by the research, right? So we've been talking a lot about how do we integrate research early on. Some policymakers will be proactive about that, but on the whole, they're not. So I think we as researchers have to get more savvy about communicating about our research in ways that anyone can understand, right? It's not about showing how smart we are. It's really about making sure that we disseminate that information and that we talk about it. You should be on a podcast.
I'm sorry.
Great idea.
Please continue.
No,
I couldn't help myself.
No, that's fantastic. But I think that's true. I think that's absolutely true, right? I mean, honestly, I started working in this field, almost 25 years ago now, and podcasts wasn't even on anybody's radar. But we talked a lot about this central problem. And the reality is policymakers, that's how they're finding out about things. They're listening to podcasts. They and their staffers are looking at Twitter. They're looking at LinkedIn. They're trying to find out who's saying what about what's happening. And then they dig deeper. So we also have to adapt, again, sort of get out of our ivory towers and really think about, go to where people are, talk with them about these policies and their implications, but also help them to understand the implications of our research and hopefully in the end also make our research more responsive.
So that's great. And my guess my final question, and I really don't know what you're going to say, is have the policymakers shown an interest? Are they taking your calls? Should we be optimistic about them listening?
Yes. So I think they definitely are. Certainly here at Stanford, the Human Centered Artificial Intelligence Institute has an annual meeting where we have congressional staffers come in. It's actually coming up. And so I spoke in that last year. I'll do it again this year about the ethics of AI in healthcare. And I'll give some of those specific examples around neuropathy. We also have associations. So we have a National Association, Academy Health of Health Services Researchers, and we talk with policymakers all the time. We make ourselves available to them in a bipartisan way. It's not about the politics. It really is about elevating the science in a way that hopefully can be useful for real world decision making.
Thanks to Alyce Adams. That was the future of health outcomes. You have been listening to The Future of Everything with Russ Altman. If you enjoyed the podcast, please consider subscribing or following it so you will receive news of the new episodes and you'll never be surprised by the future of anything. Maybe tell your friends about the podcast too, and definitely rate and review it. We have more than 200 episodes in the back catalog, and you might go check out some of those which are still evergreen and good. You can connect with me on Twitter at @RBAltman and follow Stanford Engineering at StanfordENG. You can also now follow me on Threads at Russ, R-U-S-S, B as in boy, Altman, Russ B. Altman, all one word.